welcome to the first virtual roundtable presented by the Integrated Benefits Institute as part of our new IBIBridge platform. The IBIBridge is an online discussion forum designed to connect employers so that they can share strategies, insights, experiences, and solutions to their common health and productivity issues, as well as to provide them with access to subject matter experts. My name is Joanne Wojcik, and I will serve as the moderator of today's discussion, which will focus on mental health in the workforce. Even though it's been more than a decade since the landmark Mental Health Parity and Addiction Equity Act was signed into law, millions of Americans still do not have access to much-needed behavioral health care. But untreated mental health conditions are inflating employers' overall medical spending, and less than 40% of employees who say they are depressed are actually getting treatment, according to research conducted by the IBI. Employers must address this healthcare disparity soon if they want to attract, retain, and support their employees. Moreover, today's knowledge-based economy requires employees to be mentally and emotionally healthy so that they can work, perform at their best, and enable their companies to compete in the global marketplace. To address this issue, IBI has invited 5 members of the IBI employer community to participate in today's roundtable discussion. They include Clare Miller, Mental Health Benefits Manager at Facebook, who will address how stigma prevents many employees from accessing care. Jennifer Dalton, Project Manager at the Gap Old Navy, who will address improving access to care. Linda Brady, who leads value-based purchasing initiatives at Boeing, will address integration of care. Colleen Daly, Global Wellness Benefits Manager at Microsoft, will address ways to improve quality of care. And Scott Daniels, Senior Director of Disability at Comcast, will address measuring and improving outcomes. Today's roundtable will last a total of 60 minutes. First, we will hear short presentations from each of our speakers, and then we will use the remaining 30 minutes to take questions from our audience. Please submit your questions using the chat feature on the webinar console, and I will direct them to the appropriate speaker. You can see with this slide that we have up what the chat feature looks like so that you can look for it on your screen. Following today's virtual roundtable, the discussion of today's topic will continue on the IBIBridge platform. And at the conclusion of the roundtable, Marshall Riddle from the IBI will explain to everyone how the IBIBridge platform works. So now let's start our roundtable discussion with Clare Miller from Facebook, who will explain how the stigma associated with mental health conditions is preventing many people who need care from receiving it. Clare?
Thanks so much, Joanne, and thanks to IBI for pulling together this really important discussion. I'm grateful to be a part of it. So what I'd like to talk about for just a few minutes is stigma and a few of our sort of insights and learnings here at Facebook, in case they're useful to the broader employer community. The first point I wanted to make is that I think it's really important to tie any of your efforts related to mental health to an actual mental health strategy that is sort of defined and ideally ties to your mission and values as a company. At Facebook, for example, our mental health strategy, the reason we even have one is that it ties to our larger company mission and our values. We want to embrace mental health as part of our efforts to really build a stronger and healthier community in support of our mission to bring the world closer together. And so at Facebook, our strategy includes 3 pillars. One is increasing awareness and reducing stigma. I'll talk a little bit about what we're doing in that space. Number 2 is increasing access to care. And number 3, encouraging peer-to-peer support and fostering an environment where employees can connect and support one another throughout the balance of their lives, not just work, but also as humans, including mental health. So we started with, that mental health strategy, which does include reducing stigma. And what we did was really looking at the research. There's, I think, a common misconception that stigma isn't well measured and is sort of a loosey-goosey term, but there is actually a growing body of research associated with stigma measurement. And one of the things that it found, for example, one particular study comes to mind by Bernice Piscadiliano that showed that you really need to do more than just talk, for example, about symptoms and about mental illnesses and the fact that treatment works. This particular study suggested that as a society, we've grown in our appreciation that mental illnesses are real and can be effectively treated, but along with that increased awareness, stigma did not improve. And in some cases, and in particular in the workplace, actually in some cases got worse. So what the stigma research does suggest, and says actually quite clearly, is that the best way to actually reduce stigma is for people to connect with other people who have actually the experience of mental health, so that you're learning about depression as part of my life in the full context of who you know me as Clare, as a hopefully productive, effective professional, and this is one part of me. So at Facebook, what we actually did was to develop an initiative building on our core value as a company of being open. We launched an initiative called Open Up. And what we encouraged folks to do was to share their personal experiences on Workplace, which is the platform we use here at Facebook to both work and to connect. So that's where we actually are doing our daily work and connecting with our project teams, et cetera. So folks were invited to share their experience related to mental health. This could be anything from a personal experience with a mental illness. It could be how they manage stress. It could be focused on caring for others with mental health issues. It really ranged the gamut. We had great participation from a wide range of folks around the world as part of the company telling their stories. So this has been an initiative that took place not just on Workplace, but really in all channels. We looked at really every opportunity where we could embed mental health messages into existing efforts. So, for example, we have leadership days with our employee resource groups. And at Women's at Leadership Day, for example, we made sure to include mental health and resiliency as part of that messaging, as well as actually developing kind of standalone mental health specific events and communications. So for us, and I think for many, it's about looking at really all of your channels and all of your leaders and how can you engage various parts of the company to make sure that the initiative really kind of comes alive. We also did things like installed in all of our offices around the world posters and wall installations with some of the visuals associated with the Open Up campaign, which included these beautiful illustrations with butterflies, which is sort of the image that we use to signify Open Up, capitalizing on the analogy of metamorphosis and change and growth. Another point that I wanted to make was that the importance of really looking at cultural and regional differences and really designing for diversity. So we think it's important to not think of sort of after the fact, okay, we have an idea, we'd like to execute on it now, how can we make that idea work for diverse communities, but really make sure that those considerations are at the very beginning of the conception of a strategy. So we did a lot of thinking about whether Open Up would be sort of too bold for some regions, and then tried to tailor how we actually specifically executed in different regions based on some of those regional considerations. So for example, in APAC, we really leaned in heavily toward engaging some champions, especially in some of the leadership levels, to make sure that we would have good participation and support at the highest levels to really kind of send that strong signal that this is an initiative that's important to the company. And then last, but definitely not least, focusing on measuring everything that you can. For us, this meant, for example, measuring engagement. How many stories did we have? We've now done 2 phases of Open Up. And so we're already seeing increases in terms of more people, getting comfortable with the idea of opening up and sharing on the platform, as well as, engagement in events, attendance at events, and of course looking at trends in terms of utilization for our various benefits and programs. And then lastly, we're also beginning to try to measure stigma in our surveys that we do across the company of employees. So we just rolled out this past year some questions within that company-wide survey that really get at stigma and talked with a lot of the academic experts about what kinds of questions we could put in there related to stigma to really establish a baseline so that moving forward we can hope to measure change against these various stigma initiatives that we've rolled out. Sorry, that's my timer to make sure that I'm not talking too long. So in summary, I guess what I would encourage employers to think about is to think really strategically about how you want to approach stigma, have that fit into your larger mental health strategy, and then look at the specifics of how your company communicates, how managers show up, and look at ways that mental health can be improved and stigma can be reduced by leveraging all of those things at your disposal.
Very good. Thank you so much, Claire. Now we're going to hear from Jennifer Dalton, who's going to describe how Gap and Old Navy are solving access issues for its employee population. Jennifer?
Great. Thank you, Joanne. So we're looking to solve the access to care for our employees here at Gap Inc. and Old Navy. And so what we wound up doing was looking at what we currently have with our EAP vendor. And at that time, we were looking at the low utilization rate. Our employees were not using this service at all. A lot of them probably didn't even know what the service was about. So we were looking at that and deciding how we can go ahead and improve the employee experience. So we looked at our population. So we have a full-time population of 25,000 in the U.S., and we have a part-time population in the U.S. of over 120,000 employees. And until recently, with our old EAP vendor, our part-time employees had to get a manager approval in order to access short-term counseling through the EAP service. And our full-time employees did not. So it wasn't surprising that our part-time population barely used this service. And those that actually did go ahead and go through that process of getting that manager approval, a lot of them didn't even then go on to schedule counseling. So we had to identify these issues of why our EAP service was not being used. And so some of these issues, in looking at our part-time population was very underserved. So it's a huge population for us. They mostly work in our stores, and they do so much for our business. They are the first contact for our customers. And for them, in order to get short-term counseling, was not an easy process. And some of the other issues faced by not only part-time employees but our full-time employees was confusion with what the EAP service offered. Those that actually knew what it was thought it was just, it's for mental health. I don't need to use this. I don't need any mental health services, and didn't realize all the other services that were offered. Also, too, we found that getting access to a therapist was not a quick process. It could take up to 8 weeks. So it wasn't, nobody could get to talk to a therapist quickly. And also, too, as a company, we didn't really know what our employees' mental health issues were. So what we tried to do, or what we are trying to do to solve this, is that we went ahead and we switched to a new EAP vendor, and that started July 1st of this year. And with that switch, we also decided to change kind of our format for the EAP. We felt that if we went ahead and marketed EAP to our employees, they would go ahead and think, it's just mental health. So we decided not to market it as EAP, but market it as a concierge service format, and basically saying it is one number to call for all your benefit needs. And here at Gap Inc., Old Navy, there's so many different programs for our benefits, so many different vendors, phone numbers, logins for this, and that. It gets very confusing. So we felt that if we come up with this concierge service, one phone number, if you had any questions regarding any benefits, you can just call this number. And our new EAP vendor would then go ahead and be able to move you to the correct area regarding your benefit needs. Also, too, with this concierge service, another opportunity we found is that if an employee went ahead and called, say they had a question regarding financial services, the person taking the call could go ahead and start talking to them about, okay, financial services needs, what are your questions, where I can direct you. But at that point, they can also go, you know what, you sound kind of stressed. Can we talk about this? So it's also a great opportunity because the employee calling might not realize how stressed they are about, financial services or something else. And the person taking the call in our concierge service format can go ahead and pick up on that and then, go ahead and then decide, what, maybe you need short-term counseling, or, we have other wonderful programs within the service too, like a mindfulness-based training. So an employee calling can be calling for one thing, but also wind up coming away with something else, not realizing that they needed help in another area. So another thing we also heard from our employees that getting access to care was difficult. So we have partnered with Spring Health, and we had done a pilot with them last October, which actually ends this October. And with this pilot, employees can go ahead, log into the site, take a 5-minute assessment, and then go ahead and speak with the care navigator. And then this care navigator will go ahead and be able to talk with the employee regarding the assessment and possible next steps. And then an employee can also from there go ahead and make an appointment and then see a therapist within a week. So a quick turnaround time versus the conventional, it could take up to 8 weeks to get an appointment. With Spring, an employee can go ahead and basically get an appointment with a therapist within a week, as well as everything with Spring is virtual. So it's more convenient, more accessible. You don't have to worry about Monday through Friday, 9 to 5. I've got to sneak out of work to go see my therapist. But here you can go ahead and do this in the convenience of your home, during lunch, on vacation, whatever. So it's definitely more accessible. And we've heard back from our employees that they love this service. It's amazing. It's being used a lot, and people are really liking it. So also, too, within Spring, the assessments, what's great about that is that it takes 5 minutes. An employee can go ahead and see at that moment, this is what's going on with me. I didn't realize this. And we've heard back from some of our employees who have gone on maternity leave, and they've gone in to take an assessment because they were not feeling right. They didn't know what was going on, and by taking this assessment, they found out they actually had postpartum depression, and they were able to go ahead and get that treated based on the fact that by taking this assessment, it identified that for them. So it not only helps our employees get kind of a pulse check of where they're at mentally, but it also lets us know as an employer what our employees are going through, because we never really had that from our employees. We never were able to figure out, pinpoint what was going on with them. And also, too, with our concierge service, we still do have short-term counseling offered. So our employees do have a couple of different ways that they can go ahead and access, mental health care. So anyway.
Very good. Thank you so much, Jennifer. Now we're going to hear from Linda Brady at Boeing, which has been improving behavioral health care outcomes by partnering with its primary care physicians to coordinate care. Linda?
Great. Hi. Yeah. Hi, everybody. So I just want to talk a little bit about the things that we're doing with our ACO partners in particular. We have direct contracting agreements with 4 health systems in 4 of our largest markets, and then a primary care direct contract in another market. When we started on our contracting path, we had a series of quality metrics that we required as part of our agreement. And the key metrics that we had on mental health were depression screening and managing patients to remission and measuring that This was relatively new for our health system partners. They had not been routinely and systematically recording the screening, doing the screening at the primary care level, and even measuring to remission. So initially it was a huge hurdle for our ACO partners to achieve and accomplish, to set up the infrastructure to do this, as well as provider behavior. All of our ACOs struggled in this area initially. They've since gotten much better at it. In our first year with 4 partners in 2016, we brought all of our ACO partners together for a summit. And one of our lead speakers was from the University of Washington Medicine. They were our first ACO partner, but they also held the honor of being nationally recognized for their work in innovation around mental health and primary care. So they came to speak about a program that they have launched and have been talking nationally to other systems about regarding integrating behavioral health specialists in the primary care environment. And the results that they were seeing were very promising, both in terms of finding and tracking and monitoring patients with depression, but more importantly, giving patients and primary care docs immediate access to expert resources and care. With behavioral health, as you heard from the other speakers, telling a patient in any kind of health setting, you call this person and set up an appointment, the likelihood of them actually leaving that appointment to go do that and then keeping that commitment is very low. And the patient then continues on the path of not being treated or addressing the concern. So our UW Medicine partner came and talked to the other ACOs about what they were doing, how they set it up, what their successes were, how to get something like this started. And in fact, they offer consulting services and even partnered with some of our other ACOs to get their programs started. By 2017, we had all of our ACOs with some type of solution where they had embedded behavioral health specialists in the primary care setting. What this allowed our ACOs, our primary care docs, and our ACO systems to do was 2 things. It helped them understand some of the treatment parameters around behavioral health that primary care can at least initiate and start. It helped them understand how to recognize the signs that treatment might not be working and when it was appropriate for a transition or a handoff to an actual behavioral health specialist. It also helped them and guided them on how to talk to patients about behavioral health and mental health concerns and issues, got them more comfortable having that conversation and doing the screening. In addition, it provided a resource within the office walls where they could walk a patient down and actually have an immediate consultation or conversation with a behavioral health specialist to start assessing and addressing the type of concern that the patient was facing. It sort of minimized some of the burden that's already placed on primary care doctors to be an expert, a little bit of an expert in all fields, if you will. So it alleviated the burden, but also helped expose and train and educate a provider community on how to treat key things like depression and anxiety. Outcomes that we're seeing from this, we are seeing improved performance on depression metrics. More of our patients, based on the measurements, are actually achieving remission or at least a response to depression where their PHQ-9 scores are going down. We have more members getting screened for depression and anxiety. And the primary care doctors are experiencing some level of relief, both in terms of better and improved understanding, but also knowing that they have resources that are immediately available to them to help with patient care. There have been many evolutions on the model. Multiple approaches are being considered or actually deployed. The first space that most of our ACOs started was really bringing that behavioral health specialist on site into the primary care setting. But we've watched them do a variety of different things where they actually start integrating behavioral health specialists in specialty and disease management care teams, where the care managers are now accessing that specialist in certain conversations and care plans. They're also taking approaches where there's a centralized solution for those primary care practices that are maybe not conveniently located or don't have the bench strength in their infrastructure and setup, that they're actually providing that resource either virtual or on a rotating basis. And they're including behavioral health specialists in hospital settings as part of the discharge teams to help talk through and help patients understand what their care will look like when they leave the hospital, assuming that all inpatient experiences have a mental health component to them. One of the things that we hear a lot from our ACO partners is finding the right resources continues to remain a challenge. Trying to find them and onboard them and employ them has been a challenge. Reimbursing for this type of support and services, not all health carriers are ready to process claims for these types of additional services. So it often requires a system to have some level of upfront investing to make this happen. And then the question becomes, should employees pay for this additional service, or should it be free to them? And then change can be slow. Trying to get this started in a practice, in the right practice, learning from that start, and how you then scale it and roll it out to your other neighborhood clinics or primary care clinics has been and introduced some challenges. Some of the benefits to this, when they first came up, started talking about integrating behavioral health with primary care, the team was looking at the demand for time with a psychiatrist or therapist, combined with those specialists and their capacity to take on these patients. And what they quickly discovered was there was no way the capacity that they had could possibly meet the demand. And that's what got them thinking about how do we start helping these patients with a variety of different licensed levels so that you can balance who actually needs to see the psychiatrist and who doesn't. And how do we help primary care practitioners who are often the ones, at least initially, prescribing the medication? How do we help them understand what the treatment protocol should be? More importantly, how do we help them manage these patients who are doing it? And then the final comment that I'll make is it's more than just inserting these behavioral health specialists and walking away. It also requires a system for tracking these patients and these providers who are delivering care in a registry that allows a champion, a physician champion, to monitor how patients are responding, how they're doing, to monitor how providers are doing. Are they responding? Is more help needed? And if there are patients that would benefit from additional intervention by a higher level specialist. So that's the work that we're doing with our ACOs. We're excited about the progress we're making. It's led actually to additional innovation around access for care that happy to speak about if time permits.
Excellent work. Thank you so much. Now let's turn to Colleen Daly, who's going to share Microsoft's integration of care strategy. Colleen?
Yeah, Microsoft just recently established a headcount on our benefits team looking at healthcare transformation, and that's a role that I've switched over onto the Microsoft benefits team. And really the goal of this new role is to leverage Microsoft's influence as a global company to really transform end-to-end healthcare experiences, not only for our employees, but also in the marketplace. So really using the expertise that we have as one of the largest payers in the marketplace and also providing first-in-class benefits to really push our local partners in the marketplace to really transform healthcare and try new things with them, really call them out when they're not performing to a standard, really looking at what are the barriers, and also partnering with our Microsoft artificial intelligence and research team to really think about how can we solve some of those barriers that are in the marketplace. And we started our journey around specifically focusing on mental health about 18 months ago. We've ran 2 mental health campaigns in the month of May. We went pretty bold with our first launch on that, and really tried to be upfront and really push the topics as much as we can in the beginning. It's centered around it's okay not to be okay, and it's okay to ask for help, things like mental health manners. We also, in the last 2 years, and just this past Tuesday, sent an all-employee email globally to all our employees, and I think that's another good point. All of our initiatives that we do around mental health are global, so we take a very similar approach, being culturally sensitive and understanding how it applies globally and offering customizations, but in general, we try to leverage everything that we do in the U.S. and understand how it can be applied globally and make it available to our employees globally. So this past Tuesday, we just sent out the suicide awareness email to all our employees globally with a pretty bold message of break the silence, break the stigma, giving 5 tips on how to prevent suicide. I think this was something that we talked with our Middle East departments, our Asia departments, and really understanding how this message can resonate with them. This message was sent to them. We have a great response. Our employees, our leaders globally have sponsored this and really kind of forward the message, talk about it in their town halls. So it's been great to see kind of how Microsoft has really just taken this topic on internally in a bold way and having it be such a great response. And with that, I think it's really pushed our employees to give us honest feedback on the quality of providers that they're seeing in the network. And so it's really, they'll come to us and say, I had this experience. It wasn't a great experience. How do you solve this? And so we're leveraging that feedback to really look at the local marketplace and influence change. So any of the suppliers that we have on-site or through virtual suppliers, we always look at quality with those providers and making sure that we're signing high-quality contracts with them. We've established behavioral health working groups with local hospitals. We meet with the local hospitals and their behavioral health departments, and their leadership team is also present. And we talk about what are the challenges in meeting the behavioral health needs within the population. We talk about how we can increase visibility for them to know what our resources are for employees, because a lot of times they just don't know what the resources are. We push them on standardizing some of the PHQ-2 as part of their primary care visits. So we're having very transparent conversations with them. We've also established active partnership with other external organizations, such as the Brady Collaborative or Global Business Group on Health. I'm serving on one of their working groups related to mental health, looking at Pacific Group on looking at how we can establish maybe a partnership across companies. And then also another thing that we're doing is partnering with our health plan administrator to increase the quality of the network. And some of the things that our plan administrator is doing, which is Primera, is they're looking at how can they implement value-based contracts with the behavioral health providers to tie unit cost increase to performance on some commonly accepted behavioral health industry standards. They're partnering with best-in-class substance abuse facilities and creating national centers of excellence for substance abuse treatment based on the most current evidence-based care. They've implemented and promoted a virtual behavioral health provider, which is Arcadian. So they've provided them in network so someone can see them as part of the covered benefit that's in our plan, or they can also look at using that as part of the EAP benefit. And they've also focused on behavioral health HEDIS measures such as medication adherence or antidepressants. They're also promoting the uptake and scaling of collaborative care model with network providers in order to integrate behavioral health into primary care, which increases access and improves quality of care and outcomes. So all these things that our plan administrator is doing, we're in close partnership with them and really help make sure that with the work that they're doing and pushing, Microsoft is equally using our leverage in the marketplace to think about how we influence the quality of care, because we all know that not only is there a shortage issue, there's also an issue related to quality when it comes to behavioral health.
Most definitely. Thank you, Colleen. Our final presenter, Scott Daniels, is going to share how Comcast consolidated its EAP and behavioral health care provider network to improve care coordination and treatment outcomes. Scott?
Thanks, everyone, and thanks for taking the time this afternoon. So, yeah, Comcast, we've had an interesting journey on the in the behavioral health space, and I think, a lot of information on this slide, but I want to call out a couple things. While we really we kind of stepped back and took a very much holistic approach to how behavioral health was impacting Comcast as a whole, and so we have large call center operations, and we have field technicians, and we have a bevy of different employees, and we know that behavioral health has impacted us in a large way. And some of the low-hanging fruit in terms of what we see is in our claims data, but instead of trying to attack a problem from a disability perspective or an absence management perspective, we really took a step back. I partnered with my peer, Jill Person, who has done a great job of really thinking about the behavioral health strategy and how it impacts our company as a whole. And so I kind of want to focus today on some of the practical solutions that we've done, one of which was consolidate our EAP, so our EAP and our behavioral health network, which was a tremendous effort. And in doing so, as you can see, we saw EAP utilization go up dramatically to the tune of 30% in the last couple of years. Another thing that we did simultaneously with this was a behavioral health. It was an approach to short-term disability behavioral health claims where we made treating with a licensed behavioral health specialist a requirement. And so here's an example of where we are looking to have an impact on things like disability durations and disability incidents. And while we didn't see such a tremendous impact there, we did see it contribute to the increase in EAP utilization, thereby making or showcasing our population interacting with our EAP more, which was really, really nice to see. You can also see that some of the outcomes we saw, which has been just a tremendous result, is our behavioral health outpatient visits declining to the tune of 20%. So again, there's barriers to treatment, which can be cost, and we've kind of addressed that. But we also saw an ancillary positive, which was the decline of that outpatient visit, the out of network visits, which has been great. And so that's where you're seeing the drive for more business performance. So it's a mix of kind of trying to create a much better employee experience through optimal treatment, as well as driving more clinical within the process. I'll also say that, again, we did not look at trying to solve one problem. We looked at trying to have a broader impact. And so when you think about outcomes, I think it's really important to not just focus on things like disability outcomes or leave durations or incidents. Think broader. Go into what these incident rate and what durations can do for downstream impact to medical costs. Here with us, you can see EAP usage, and then certainly workforce implications. And so some of the other employers have addressed this with some unique ways to do it. And I think for us, getting that optimal care when they need it has broader implications downstream for potentially preventing that person from going out again. And so one of the really nice statistics we've seen over the last couple of years since we've launched our initiatives has been return to work statistics. And so while everybody has a different return to work strategy, what we saw in the wake of creating this new process on the disability front was people were coming back to work from disability claims and not going out on other leaves. And for us, that was very significant because we were getting impacted by disability and then a continuation of leave after that. And I think that's really important to point out. Certainly for Comcast, it has given us the ability to kind of take the next step in our journey. And so I would say that, the increased EAP utilization has been great. Optimal treatment has been great to see. It's the beginning for us as we're starting to move into some areas like on-site clinicians and seeing where we can measure and have that kind of impact there. So we're in the midst of a journey. And like I said, we've taken a much broader look at this journey than trying to influence one thing.
Well, thank you, Scott. Well, now that we've heard from our presenters, we'd like to open the floor to questions from our audience. And please use the chat feature on the webinar console. And as your questions come in, I will direct them to the appropriate speaker. And we actually do have a question that came in earlier. Our first question is for Jennifer from the Gap Old Navy. And that question has to do with, is there a way to digitally navigate to the EAP, or do the employees have to call and use the phone, essentially?
Yes. So with our new EAP vendor, there are other means. They could log on to the website, and they do have other features where they can digitally go on and access, set up an appointment, ask questions, and things like that. So it's no longer just they have to call anymore. So there are other means for them to go ahead and access the service.
Very good. I have another question for you, having to do with why was it essential that the part-time employees get manager approval and the full-time employees did not have to in order to access? Why was that the rule?
Well, the rule with the former EAP vendor was it was a cost issue. So it was super expensive for us to be able to put over 120,000 employees onto the EAP service with no approval. So when it was made, that rule way back when, it had been decided that that was the best course at the time. But then over the years, and we were with this prior EAP vendor for like 15 years. So, in looking at the utilization rate and how low it was and how it would just, our part-time employees just didn't have that easy access as a full-time employee. So we really went and rethought about how we can improve that employee experience, not just for full-time, but for part-time employees as well. But to answer it, the main issue was cost.
It's always about cost, isn't it?
Yes.
We've got a question here for Linda. What would you say the biggest barrier for integrating behavioral health into primary care was?
So from our perspective, the barrier was really around finding the right resources and then figuring out how they were going to use that resource across their multiple primary care practices. Some systems actually did the physical embedding of the resource in their largest primary care practice and or the practice that had the most number of patients moving through it. Others took the approach where they had the specialists rotate from office to office. So they were there to provide immediate support to primary care docs, but it ran the risk of introducing a delay for members getting care. But I'd say that is the challenge and continues to be the biggest challenge, along with primary care docs still having a long road ahead of them in getting comfortable talking about mental health challenges with their patients.
Yes, definitely. So I have a question for Colleen here. You mentioned that you're rolling this program out about suicide prevention globally. Has Microsoft been tracking suicide rates globally? Do they, vary by country?
So I definitely have visibility into the suicide rates at a concrete level within the U.S. We do not collate our suicide rates across all of our countries. I do have some visibility into it because we do hear about it, but as far as like collating across all of them, that's not something that I have currently requested.
Now, I've got a question here for Clare. So if a company doesn't have a culture like Facebook, how can they start addressing stigma?
Yeah, I think it depends on where you are now, right? And reducing stigma is the reason to reduce stigma is to get people connected to care earlier, to help people be their full selves without shame. So, I would encourage companies to think about where are they now and where can mental health be kind of added into existing efforts. And are you talking about other topics that connect to mental health? Because so many different things do connect to mental health. Are there opportunities there? If your company's really forward in terms of talking about financial wellness, you could add in messages related to stress there. So looking for those opportunities. And then I guess the other thing is to think about champions. And, in our work, we often hear about cases, escalations, et cetera, where maybe it's someone that has shared, what they're going through. And sort of just keeping your ear to the ground to, are there people that you could kind of foster and nurture to become eventual champions for the topic. And then the last thought that I had on this is focus groups. We do a lot of focus groups here, especially on topics where we really want to hear more from employees about what the real day-to-day concerns are that maybe we wouldn't see in more quantitative analysis or qualitative analysis through surveys, but to really have that rich dialogue where you're able to kind of double-click into headlines and really understand what the challenges are. So just beginning to talk to people to find out what this, how mental health is showing up in their world and what they think the company could be doing about it is a great way to source ideas and also to build that, kind of community of champions.
Well, I've got a question for the group here. How is mental health integrated into workers' compensation injuries? Does anyone want to take that one? No take.
Hey guys, so this is Scott here from Comcast. So I would just say that I think workers' comp is complex in a sense because you have the various different state laws and some states it can be compensable, in some states it's not. But what I will say, and dating back from my time in practice with this, is that I think that it's incredibly important to not fragment the two or segment out the two or what we like to say, have them run off in silos, because it's so important to recognize that if somebody's out for workers' compensation and is missing days, that in the state of New York, and I'll that's where I spent my time in practice, is there could be something called consequential injuries. And many times what you see is somebody's dealing with a chronic pain situation. They could consequentially or ultimately be dealing with some kind of behavioral health condition. And so while there may not be one practical solution, I think it's really important for risk professionals and the benefit professionals to be aligned in an approach to weave in things like EAP and weave in some of the behavioral health programs that, again, this list of employers probably offers up a bevy of. And so we shouldn't relegate it to just, well, somebody's out on disability, we should offer them this program. If somebody is missing work, we should always be thinking about how we can weave in our EAP. And I can tell you from Comcast perspective, we really look to our EAP to treat employees. We look to our EAP as a very much so robust vendor that can help with work and life or life in general. And so I think it's really important. I know I'm going a little bit broad here, but from a workers' comp perspective, be mindful that just because somebody's out with a physical injury doesn't mean they may not have a consequential behavioral health condition on top. And so it's really important that we weave in things like the EAP and other programs, and should be doing that on the front end. So I think that's important. It's a great question. There's not a right answer to this, but risk and benefits should be aligned in this, and oftentimes they're separate.
I've got a question here. Are any of you using pharmacogenic testing programs to identify optimal medication for individuals to reduce drug failure and increase adherence? So
this is Colleen from Microsoft.
Hi, Colleen.
We have Walgreens as our on-site clinic pharmacy provider. So we often listen to a lot of what they say and kind of recommending in the marketplace as to what we should be offering our employees. And there was pretty strong evidence on their side to be able to say that there's a lot of benefit for pharmacogenetics, especially related to some of the behavioral health conditions and the struggles that people have on finding the right medication match, the right dose. In the end, I think what it came down to is Primera, our health administrator, they use arm, which is a kind of they evaluate the evidence base and understand if it should be part of a plan. And their current perception is that there's not enough evidence yet to understand the benefit of offering pharmacogenetics as part of a plan. Walgreens had approached us to understand if we would want to do a pilot. We were just hesitant to do something outside of our plan. I think that there is a lot of really good support showing that it could be something that's really beneficial for people. It's just really hard when we have a plan of our size to try to make a decision with that, and how do you really make the appropriate guidelines that could work across your whole plan, because there's variability in the marketplace. And while it might be really beneficial for one medication, it might not be beneficial in another scenario. And so it's just, at this time, we just felt like we just didn't have enough information to really make a decision as to whether we could add it to our plan or not. But it's something that we've kind of tabled and we want to continue to monitor.
Does anyone else want to answer that question, or should we go on to the next? Okay, we'll go to the next. So is anyone other than the Gap Old Navy using a behavioral health navigator to help employees get to the right resource?
So we are, this is Linda Brady with Boeing. So we too have an EAP program that operates in a similar fashion, where they're there to help navigate to behavioral health resources. But we just launched a pilot with one of our ACO partners to get people, when you call this number, you can be connected directly to a psychiatrist or a psychotherapist during that call to help with a second opinion, to discuss what kind of specialist they may need. And then they have a health navigator as part of the solution to help find the right resource for any follow-up. Sometimes it's actually the psychiatrist or psychotherapist making the appointment with the caller themselves and using their own capacity and calendar.
This is Clare, and Facebook is using Accolade, not specifically and only for behavioral health, but for all of health. And one of the things, and they know and are connecting and warm transferring to any number of our other benefit programs. It's noteworthy though, because we have seen a nice increase, and we already had a pretty healthy utilization to start with, but we're seeing some increases in terms of people connecting into LIRA. We don't call it EAP here, but to our LIRA benefit since the introduction of that program. So then they can go deeper if someone needs, someone's about to be hospitalized or is coming out of the hospital. They have deeper sort of case management capacity within that Accolade structure. But that's been a great change for us.
We've got a question here for Clare. Can you give a few more suggestions on how to engage leaders who don't see this as a part of their job or a strategic priority? Yeah.
I think this is a real challenge. I think, Facebook, we had a huge head start here with Sheryl Sandberg and her work on Option B. I think what I would say is to listen to what they are talking about and what is keeping them up at night. And, mental health is one of those topics that connects to so many other things that, starting with what it is they are struggling with and seeing if you can, bring in the mental health angle to something that they really care about, and to show how focusing on mental health can help to advance whatever challenge they're dealing with. There's often a way to do that, so I think it's sort of thinking really creatively around, what are their concerns and how could more attention or more support or more investment or more dialogue contribute to solving the challenges that they're passionate about.
Okay, I've got a question for Scott. how is the mandatory EAP for behavioral health disability claims coordinated, and are they also able to certify the leave?
Yeah, so again, we rely pretty heavily on the collaboration between our third-party administrator and our EAP, and so by making it part of the process, which again, fully legal and the way we stood it up, we're not dictating who the person actually treats with, but giving them kind of assistance around, could be what's a bevy of providers to help them along the way. It's done through similar to a certification or what we call an attending physician statement. And one of the cooler things that we've actually seen by setting up this process is via our relationship with our EAP, ComPsych, we have created, in conjunction with this, almost what seems to be like a preferred network. And all this really is a network of providers that are comfortable completing paperwork around a disability claim. And this is probably one of the biggest epidemics across the claims landscape, which is providers, doctors, licensed behavioral health therapists, things, you name it, sometimes have difficulty completing paperwork, or more pointedly, making opinions and speculating about the ability to work, not work, how long it's going to last. And so this kind of preferred network of providers that understand the paperwork and can come up with two main things here, which is really what we're looking for: a return to work plan and a treatment plan. And I think oftentimes in the behavioral health space, those two things get lost. And so with our EAP driving this process, it's really greatly beneficial for our employee, incredibly beneficial for the claims process, which can be tedious, and just overall driving optimal treatment. So we've seen the process has evolved over the years. It has not been stagnant. It has been a living, breathing thing. But it's really been nice to see the vendors collaborate and really see this clinical side being integrated into the process. And like I said, driving two main things: treatment plan and a return to work plan. And that's really been helpful for us.
Okay, now we've got a question for Linda. When developing ACO partnerships in the largest markets, do you have suggestions for addressing concerns of inequalities of access for a global company to the point it prevents progress? Linda.
We're very careful about that, and our partnerships include, investment in those members who choose to enroll in an ACO plan, and those members who either can't enroll or choose not to, but still use the ACO partner for their medical care. So we do have incentives and parameters around some of these access solutions, some of these quality improvement activities to apply to all of our members, whether or not they're enrolled in a partnership. For us, the end result is true transformation, and we do not believe that you can succeed in this space if providers first make an assessment on who employs you before they follow a protocol or deliver care or even confirm an appointment or availability. So that's a critical component of our guiding principles.
Thank you. I've got one final question before we sign off and hand off. What data challenges do you all face in linking mental health to outcomes of work, absence, and performance? Data question. This is the age-old question. How do you link your mental health outcomes data and your work absence and your performance? Does anyone want to take that question?
This is Colleen. I think as a whole across our benefits team, we haven't done a really great job about that. I think that we have recently, with some of our other vendors, started piloting some ways that we can very strategically and rigorously evaluate the impact of the programs. I think to date, we haven't gone deep on that with some of the mental health specifically because a lot of this is the right thing to do. I think what we plan to do is look at some of the learnings we have. We've put in some really rigorous predictive analytics and holding vendors to outcomes. And then we hope to learn from those experiences and understand how it applies to our other areas across benefits. But I think that's definitely one area that's been a challenge.
Yeah, definitely. Thank you, Colleen. Well, it looks like we've reached the end of our time for today. And if you didn't get to ask your question, or if your question wasn't asked during today's program, and you would like to connect with any of the speakers or other participants, you will be able to do that using IBIBridge, and the discussion will continue virtually. And to learn more about how to access the IBIBridge, I'd like to introduce Marshall Riddle, Digital Marketing Manager for the Integrated Benefits Institute, who will tell us how it all will work. Marshall?
Well, first we'd like to thank everyone for taking the time to log on and join us today, especially our speakers who, were gave very good presentations and were appreciative of their time. As you can see, there were a lot of questions, and there are even more that we weren't able to get to. And so on IBIBridge, you will be able to continue asking questions as well as view any of the questions that weren't answered today, see the answers that come across there. You will receive within the next day or two instructions on how to log in and access IBIBridge. From there, you'll be able to ask questions, communicate with each other, as well as see new resources that may be available to you. If you have any questions or would like to talk more about how IBIBridge will work, you can reach out to me. My email is mriddle, M-R-I-D-D-L-E, @ibiweb.org. And so for that, we'll thank you so much for joining us, and we'll look forward to hearing more conversations on IBIBridge.